Well, thank you very much. It's really a delight for me to be here, as well as an honor. And what I'd like to do is, for many of you who may not be aware of the American Medical Association, to talk a little bit about who we are and why our involvement with quality, safety, and health system reform is very important. As was mentioned, the American Medical Association has been around for a while. It right now is the world's largest physician organization, as well as the largest organization in the United States. And it was created back in 1847. This was the picture in Philadelphia of the creation, where 40 state societies and 27 medical schools came together to create a national organization devoted to the medical profession to do a couple of things. Our mission really hasn't changed. It's really to promote the science and the art of medicine and the betterment of public health. And our first priorities, which are priorities that have not changed, which is standards for medical education, ethics, and quality. In fact, this year is the 100th anniversary of the Flexner Report. And many of you have heard in the United States in 1910, this is the title page of Medical Education in the United States and Canada, that Abraham Flexner went around the country based on a $10 million grant from the Carnegie Foundation and published this based on standards that the AMA created to evaluate medical schools. And if you take a look at actually the table of contents that talks about the proper basis of medical education, using the course of study through laboratory in the first 2 years, and then the hospital and medical school. But finances were a challenge way back then. And of course, if you really take a look at the time period that this was done, Reconstruction, that is post-Civil War differences between the South and the North, the ability of preparation of education varied, as well as at that time in 1910, there was a difference in the education of women as well as minorities. And these are things that the AMA now is aggressively trying to change with our Commission to End Healthcare Disparities, recognizing a very important need to have a well-educated workforce that reflects the diversity of our population to be able to provide the care that patients need. So what's evolved since 1910, when the AMA was the one that accredited all medical schools, was that a few years after that Flexner Report, the American Association of Medical Colleges was created, about 76 years ago. And in 1947, the AMA and the AAMC merged their accreditation process together to call the Liaison Committee on Medical Education, which currently exists. And it is the organization that accredits programs leading to the MD degree in Canada as well as the United States. So these standards right now drive curriculum. And so as we take a look as the AMA and saying, okay, it's the 21st century, we've got a health system in the United States that some would argue isn't really a system, it's more of a sector. How are we going to achieve important goals? Well, the goals that we have articulated is we want to make sure that patients, all patients, have access to high quality health care, but we also know that we need to deal with how do we deal with a reasonable cost. And so the Institute of Medicine goals of medical care that's patient-centered, safe, effective, efficient, equitable, and timely, when you take a look at simulation in medical education and the use of simulators, indeed, all of those goals can be achieved with the use of these tools that many years ago were still in its infancy, but that now are becoming more robust as part of curriculum. Because the other thing that we recognize as the AMA is how do we improve in the 21st century with measurement of outcomes or measurements of process, using health information technology as a way to improve patient care. Clearly, medical education's continuum, starting with undergraduate medical education to graduate medical education, and then continuing professional development for the 40 years of practice that clinicians are involved with, not only in medical education, but in nursing education and allied health education and pharmacy education and paraprofessional education. All of these continuums means that we need to continue to look at ways that we improve based on new science that's created, but yet also reflecting quality and patient safety. And so 8 years ago, the AMA created a physician consortium for performance improvement. And we convened together more than 100 organizations, which involve state societies, specialty societies, the Joint Commission, the Agency for Healthcare Research and Quality, CDC, and the Quality Improvement Organizations. But also, this is not limited to just physicians, because we recognize healthcare is the delivery of a team. And so those that are involved in that team-based care also need to be engaged, not only in the development of these standards for performance and measurement, but also make sure our patients are engaged, because I think one of the things that we all have recognized is our patients sometimes feel frustrated that they are not being communicated with in an effective way. And it's clear that the patient simulation scenarios that have set up how do you talk to a patient when they've had a tragic diagnosis made shows that we have huge variability. And the relationship of cultural competency, how do we test that and have someone go through that training before they have that scenario, will make it better for the patient as well as that person who's providing that bad information. So evidence-based performance measurement is really what we're looking at. How do we create a process that will lead to a better outcome? Or if we're going to measure an outcome, how do we make sure there's a defined process you can follow that will achieve that better outcome? And so as we take a look at the Physician Consortium on Performance Improvement and the creation of the Physician Quality Reporting Initiatives, these broad clinical conditions are things that we are now actively engaged with as the world is moving in the United States from a pay-for volume to a pay-for outcome, to a pay-for-value. Now, the National Committee on Healthcare Leadership has actually created some competencies that should be available for simulation. And those competencies in simulation are analytical thinking and communication skills and team leadership and innovative thinking and strategic orientation, and clearly you need to have the financial skills to put these packages together. But also, how do we seek new information? And then lastly, since you're dealing many times with personnel, how do you have the management of human resources to be able to have the scenarios, the standardized patients, as well as those dealing with the equipment? And so, as I mentioned, the American Medical Association's Council on Medical Education has been in existence for over 100 years. And so our council is really the eyes and the ears and the intersector with medical education. And so it produces reports that the AMA's House of Delegates adopts, and that creates our policy. Now, sometimes people will say, well, the AMA, not many doctors are members of the AMA. Well, the reality is the AMA's policy is created by a House of Delegates that meets twice a year, that represents every state, over 100 specialty societies, medical students, residents, faculty of medical schools, young physicians, women, minorities, ethnic groups, gay, lesbian, and transgender physicians. So it's a broad base of American medicine. And those policies are developed on medical education through our Council on Medical Education. And as a result of that, as we took a look at what were some of the barriers to clinical simulation, it was clear that there needed to be additional funding of research to know how best to implement this, how best to make it part of the curriculum at the undergraduate, graduate, and continuing level, not only for teachers,